All right, so well, I wanted to thank Sean and everyone who pulled this conference together today. It's great to be here with a group of wonderful people like this. The speakers today are just amazing, and I'm honored to be part of the panel. So let's get started talking about my favorite subject outside of my children, which is type 2 diabetes and how we can all collectively work together to combat this disease. So here's my disclosures. And the purpose here, I won't read all of these out loud, but purposes here, we're going to try to cover a lot in a short amount of time. So I'm going to go into it. All right, so what's the problem here? I think we all know in this room, right? The problem is that we are in the midst of an unprecedented epidemic when it comes to type 2 diabetes. Over 50% of the adults in this country have diabetes or prediabetes, over 50%. Now pause for just a minute here. Let's imagine that this was an infectious disease. Over 50% of the adults in this country had an infectious disease. What would be happening now? Not only in our politics, but in healthcare itself. We would be in panic, right? This would not be a partisan issue. We would coalesce together, and we would be doing everything we could to get to the bottom of this and fight this disease. But this disease now involves food. How come, therefore, we can sit back and take this laissez-faire attitude about it? We can't, okay? It is important, and it's destroying lives in this country. So just today alone, 200 Americans will undergo an amputation due to diabetes, and approaching 2,000 will develop severe retinopathy that we all know can lead to vision loss and even blindness. I mean, this is impacting people's everyday life, and we can't afford it anymore. In 2012, we were spending $245 billion, with a B, dollars to fight this disease. 6 years later, 327. What's it going to be like in another 6 years if we don't buckle down and do something about it? And the fact of the matter is the solution is simple, and it's right in front of us. So how did we get here, right? I mean, we got here because we have a society where increased processed foods, grains, and sugars are everywhere. But did they just magically appear? Or were they driven by something? And again, they were driven by something because this is what Americans were told to eat. Lots and lots of grains. We all remember the food pyramid, which of course has changed to My Plate. But if we see this, what we miss on the My Plate is any mention of fat, right? We see lots and lots of carbohydrates once again. And of course, industry followed. They did attempt to do and provide for people what we were being told en masse to eat. And once again, I thank Nina for this wonderful slide here. We're doing what we were told to do. I mean, we have followed all of the general guidelines, principles in the trends of our consumption. But the guidelines are just based on flawed science, right? The 2017 release of the first peer review of the guidelines show us that the guideline process needs to be totally revamped. So knowing how we got here, that it's not this problem of our patients, all of them, who are suffering from metabolic disease, just being unmotivated, right? Just being gluttons, as so many people in healthcare even and in the media say, well, if the patients were just listening, if they were just doing what we said. I mean, come on, we know how we got here. The fact of the matter is they're doing what they were told, and we're in real trouble. So now what? Now what? What if it was an infectious disease? We'll keep coming back to that. We need to change our mindset on it. There are 3 proven ways to reverse type 2 diabetes: bariatric surgery, very low calorie diet, and a low carbohydrate diet. There is literature on all three of these. This is type 2 diabetes. So what's next? Where are we going? Well, I don't know if everyone is aware, but just a couple of weeks ago, the American Diabetes Association, along with their European partners, has put, I know it's small there, but that's a low carbohydrate diet as an eating pattern now appearing in the guideline. So that's huge, yes, yes. So we're getting there. Of course, we also see a DASH diet there without the evidence to support that recommendation, but we're making moves in the right direction. So again, a systematic review meta-analysis of carb restriction in patients with type 2 diabetes. And what we see is, looking at this, even when we're looking at meta-analyses, we're seeing that, yes, low carbohydrate diets, in fact, do work for type 2 diabetes. And one of the very interesting things is the lower, the better was found. And I think most of us who are working in this field probably already knew that, right? You know, people call low carbohydrate diets 40% sometimes, right? Which just drives me crazy. But we all know that, okay, maybe that's better than, you know, the 60% often recommended. But 30% does better, 20% does better, 10% does better. And we're starting to see this in the literature too. So one of the things that I find to be the most helpful in patients struggling with type 2 diabetes is to do a very low carbohydrate or ketogenic diet. And again, I don't probably have to push this in this audience here, but what does that mean? And I like to actually concentrate on what it doesn't mean, and it doesn't mean a lot of protein. Okay, so a well-formulated ketogenic diet is low carbohydrate. For people with metabolic disease, it's usually under 30 total grams of carbohydrates a day, and it is moderate or adequate protein only. What is high in this is fats, including saturated fats, but also high in our MUFAs. And why does this approach make sense, right? Of those three that we talked about, 3 ways of reversing type 2 diabetes: surgery, very low calorie diet, and low carbohydrate diet, okay? 2 of them are mandating that people restrict their calories, right? We know after surgeries you have to decrease what you eat. Obviously, that's the premise of an extreme low-calorie diet. But we don't push our patients to restrict calories with a low-carbohydrate approach. How in the world does that work, right? It goes back to our basic macronutrients and physiology. So a calorie is not a calorie, as we've all learned, but what is really important when it comes to type 2 diabetes? It's the glucose and the insulin response, right? Of course, type 2 diabetes is a problem where glucose is elevated, so we need to restrict the macronutrient that causes that elevation, which is carbohydrates. But the most important thing here is what doesn't cause an increase in glucose or insulin. It's the macronutrient that our poor patients who have been trying to follow what they've been told have been instructed to avoid for so long. Fat does not cause a rise in glucose or insulin. So patients who have a problem with a disease where glucose and insulin are up should be consuming a lot of fat, right? Fat. If, of course, they're going to be following a science-based nutrition plan. So what does that look like? Again, a low-fat diet, predominantly carbs, a low-carb diet, predominantly fat. And notice what stays the same, right? Protein stays the same. We're not pushing protein up here, okay? We're certainly making sure that patients each get an adequate amount to maintain muscle mass, but what's changing is the carbs and the fat. So this is something that's really frustrating as patients go, but I can eat healthy carbs, right? I can eat healthy carbs like this cup of brown rice. And I bet a lot of people in this audience can eat a healthy cup, I always want to put that in air quotes, of brown rice and do fine, because they're the guy on the left, okay? So when they eat that healthy cup of brown rice, which actually contains 45 grams of carbohydrates, they release insulin to dispose of it, right? To keep the blood sugar normal. But they don't need that much of it. They have a high carbohydrate tolerance. Many of you probably in this room, you can tolerate that. Your blood sugar can stay normal. You can do okay. But our patients, the ones that we see every day coming into our office who are suffering, are unfortunately the guy in the red, who eat the same exact thing, calorie for calorie. This is exactly the same thing. And yet their response to that healthy carb is very different. They have a low carbohydrate tolerance, or we'll rename them insulin sensitive on the left and insulin resistant on the right. So why does the guy on the right have so many problems? Really a couple of things. Number one, insulin's our fat storage hormone, right? So now he's got all of this extra fat storage hormone going around, and he or she gains weight. And what does the healthcare community do? They've blamed them, right? But they're eating the exact same thing as the other person. And the second thing is, what is it taking to put out all that insulin, right? It's taxing their pancreas. We've only got one pancreas. And the longer we tax it like this, the sooner it's going to die out. It really poops out from overuse, essentially. And as soon as we can't keep up with those high levels, that's when the blood sugar starts to rise, right? That's the beginning of diabetes. But again, it started out for a long time as just being this, too much insulin. And we go back and we say, wait a minute, insulin, what's causing all that insulin to go around once again? And what's causing it not to? So important. So I love this because this is the diabetes guidelines. And what they say is the total amount of carbohydrate eaten is a primary predictor of glucose response. So let's actually be very practical with that statement, okay, and apply it, okay, but apply it with a intent in someone with a disease of elevated glucose to not want to keep their glucose elevated, wanting to bring it down. What do? We need to restrict their glucose if we want to, restrict their carbohydrates if we want to make this correct, right? Restrict it because we want their glucose to be normal. And I showed this at Ohio State too. So I have no insulin resistance. I am totally the guy on the left, okay? And I put a CGM on and I decided to eat watermelon with my kids one day. I went up to 170. Now, you can see how insulin sensitive I am because what happened afterwards? I immediately dropped right back down, right? But what if I was the guy on the right and I ate this healthy carb, this watermelon, right? This is what's happening to our patients all the time when they're given these healthy carb instructions. It's so frustrating. So this was one of our patients, though, who was the guy on the right, okay? Starting insulin dose 210 units a day, A1C 11.3. Total insulin dose today with his nice little CGM tracing 0 units, last A1C 6.1. Remember the ADA recommendations, the guidelines? Total amount of carbohydrate eaten is going to predict the glucose response. This guy's not eating much, okay? And look at the success that he's had. So another thing that we talk about when we talk about our standard of care treatment is we take the guy who's already got the elevated insulin levels, okay, already got too much fat storage hormone, taxing his pancreas already, and then our brilliant idea is going to be to add more insulin to that picture, right? I mean, we just kind of think about it in a visual like this, right? Or maybe we're giving him a sulfonylurea or any of the other medications that we use to actually kick up insulin even more. Okay? Are we helping this person in the long run? We are not. We are speeding up the vicious cycle that they've gotten themselves trapped in. So we want to couple insulin administration with carbohydrate intake, and here we go. So eating a glucose with a glucose tolerance test is going to couple with a lot of insulin, but eating fat is not, okay? Once again, it's really simple. Type 2 diabetes, a problem with elevated insulin and elevated glucose, we need to change what they're consuming so that those elevations don't happen. So what are the carb sources that we're asking people to consume? Once again, most of you know this. The one thing that I say that I like to talk to patients about all the time is no GPS. It's an easy way for them to remember. No grains, no potatoes, and no sugar. And again, the food is really good, right? We love this stuff. The 30 grams of carbohydrates can be had with some amazing food. And it's shocking to people. You know, anyone who's worked in this field, the thing when you tell people, okay, this is what you need to do, one of the first things they say is, that's the way my grandma used to do it, right? Oh, it feels good to eat that stuff again. So it's not that we're asking people to do this horrible thing in order to have wonderful success. So history of ketogenic diets, this is the way it used to be. And I got this graph, I always put it in my lectures because I love it, even though it's very confusing and you can't see it. My point is, where did this come from? This came from the Harvard archives, and my friend Osama Hamdi gave this to me. This is what it used to look like before we had insulin and all this medication. This is the craziness that physicians used to do to be able to figure out what their patient's carbohydrate tolerance was, right? We could do this again. We really could. Just take a lot of manpower. But the thing is, we lost this as an art and as a science when we got all this medication. So this idea of low-carb for diabetes is not new. This has been around. Again, the father of diabetes medicine, Joslin himself utilized this, even treating his own mother with a low-carb, high-fat diet. And she had type 1 diabetes, a disease that at this time was rapidly fatal. So it's not new. This is not a fad diet, right? We can really push back against this. Not a fad diet. And here are textbooks from way back when, right? Physicians were advising their patients not to eat the food pyramid with tons of grains at the bottom. But for any of them with metabolic disease, they were telling them to eat a low-carb, high-fat diet. And I really like this quote here because this is true. No one would argue insulin was not a lifesaver for so many patients who struggle with type 1 diabetes. For heaven's sakes, no way. But we lost our way with it, and we misused it. We misused our science by giving it to patients where there was another and a better solution, just restricting what was causing their problem. So oops is right. So what are the benefits outside of diabetes reversal when it comes to a low carbohydrate, high fat, well-formulated ketogenic diet? Well, we're kind of just scratching the surface, I think. And it's really exciting to see what the next 5 years or so of research is going to show us. But we know that it benefits the diseases that are darker. The ones that are lighter are ones where we're just starting to see the emerging science come. What comes next? We are really looking forward to seeing. So it's not just one thing either. This is something that can be applied to many of the things our patients suffer from. And I like to talk about this. Are our patients going to have no energy? Because this is a pushback we get all the time, right? They need carbohydrates to have any energy. Well, wait a minute. When they're restricting carbohydrates, their insulin goes down, and then they're consuming fat and also using the fat that they have stored. What happens to it? In the liver, it gets converted into ketone bodies, a wonderful source of energy again. In fact, a preferred source for some really important parts of us. So again, when we get that idea that, well, I'm not going to have any energy or I'm tired if I don't eat carbohydrates, actually when we start making those ketone bodies, you get that more consistent energy, not the peaks and troughs that we see with carbohydrates. And so the science about this says, let's just go through a few of the studies, and I'm going to do it pretty quickly here again in the for the sake of time. But again, this is one I really like because this was 2-year randomized control trial, really overall a good end group, but I'm interested in the subset of these patients who also had diabetes. So this was, again, a low carbohydrate, a Mediterranean, and a low fat diet. And so important to point out here again that when we talk about the low-fat diet, it was calorie restricted. When we talk about the Mediterranean diet, it was calorie restricted. But as we all know, and I'll say once again, The thing is, when we choose a low carbohydrate approach, we can do that without telling people that they have to calorie restrict. So what happened? So when it comes to weight change, I'm sure that doesn't surprise anyone that the low carbohydrate group did better. And in the people with diabetes, what we saw is the Mediterranean diet had the lowest fasting glucose. Now, does that surprise anyone who's had any experience here? No, because oftentimes when we do low carbohydrate, right, the fastings become the highest of the day, all right? So to interpret this test, or excuse me, this study to anyone who doesn't work with patients like this often, you have to say, wait a minute, the Mediterranean being the lowest of the day is actually not a surprise to us. But take a look at the A1C. Again, the A1C at 24 months was only significant in the low carb group, okay? So again, going back to the idea that generally speaking, we have low carbs, we can see a higher, higher blood sugar in the morning, and it drops during the day with their dietary compliance. And how about this study? This is another wonderful one because this was a metabolic ward study. And I like to talk about this study in people who think that they're going to have to wait a long time for results to occur. Because again, this was a 3-week study, and 1 week of it, they were doing their standard diet. Only 2 weeks were they doing, once again, a true low-carbohydrate, high-fat diet, restricting under 20 grams a day, but once again, not calorie restricting. And what happens? I mean, look how quickly this changes. Glucose and insulin, the two big problems with type 2 diabetes. Elevated glucose, elevated insulin, okay? And we can impact those and fast. So here's another one, a wonderful study by Laura Saslow, again, looking at moderate carbohydrate, which is what the ADA typical diet, versus low carbohydrate, a true low carbohydrate diet. And once again, what happens? We see that the low carbohydrate diet does better for A1C and also for weight, and without the calorie restriction. So this is another one out of Laura Saslow's lab, and this is an online intervention. So doing the counseling virtually. Very low carbohydrate ketogenic diet versus the MyPlate from the ADA. And once again, this is really an interesting thing. So she randomized this trial, right? But everyone see the dropout rate here? No one dropped out in the intervention group. And almost 40% in the control group, okay? Because they were getting and signed up for this hoping that they were going to get something that actually worked, right? This right here is a really good example of why there is a problem with randomization in nutrition trials, okay? Because patients want to do something that's going to work. And I'm sure that most of the people who signed up for this trial had heard really good success from someone with a low carbohydrate approach. So it's just wanted to point that out, important to rethink the way that we may structure our long-term, at least, trials. So what happened, though? Still, the intervention group did much better, okay? Low carbohydrate diets definitely work over standard of care. I think we can all pretty much agree on that. All right, so this is an interesting one, because this is actually a 2-year, so very good length of time, comparing a low carbohydrate diet to a high carbohydrate diet. But the low carbohydrate diet, they also tried to do low saturated fat. And I won't get into all the details of why I disagree with that as the diet premise to begin with. But at 2 years, there wasn't a difference in A1C, which doesn't surprise me, trying to do it low saturated fat. But really important, even given that, okay, what we find at 2 years is that the glucose variability is significantly decreased in the low carbohydrate group. And glucose variability has become a real hot topic in the world of diabetes, because what we found is the more variable your glucose is during the day, the worse the outcomes. So lowering glucose variability and the low carbohydrate diet group at the end was also on fewer medications. So despite the fact that the A1Cs were the same, we had some really meaningful changes here as well. Okay, so, oh yes, this is one, Eric Westman's study looking at a low carbohydrate diet compared to a low glycemic index diet. And once again, because we presume a low glycemic index diet is what? The healthy carbs, that whole healthy carb idea again. But when you compare it to a low carbohydrate diet does much better, not only in the glucose control, but more medications being reduced as well. So this is an interesting one. So this takes a look at what happens if you compare patients who have type 2 diabetes and patients who don't, and you put them both on the same diet, right? So the groups were different at baseline, but the intervention was the same. And what is remarkable, again, is when you look at the blue, obviously, was the type 2 diabetes group. At the end of 56 weeks, they match the group that didn't have diabetes at baseline. That right there is a disease reversal occurring. And we see both groups did well in reducing body weight, and both groups did well in reducing their triglycerides. But once again, look at where the type 2 group started out with the triglycerides, and look at where they ended up. Another thing to say, that's a disease reversal property happening right there. How about cholesterol, right? Because we talk a lot about cholesterol, and in both of these groups, the LDL cholesterol went down, and the HDL cholesterol went up. And this is one that I like to talk about too for patients who don't quite have type 2 diabetes yet, who are just still in this metabolic syndrome. Does it work for them? It's like they have less improvement to make. But again, this is from Jeff Volek's lab, and here we've got two very different diets, right? A high carbohydrate and a low carbohydrate diet in people before they get type 2 diabetes, and in this population it works fantastic as well. The interesting thing is, again, the calories, they were both reduced in this case, right? Reduced the same amount. So all of those improvements that were happening, again, with weight, with insulin resistance, with triglycerides, were happening where we were keeping the calorie restriction the same, okay? It's more than just calories, okay? It's more than just weight loss. Carbohydrate restriction on its own, okay, really does work. All right, so again, I'm going to go back to another meta-analysis here that was done looking at a whole bunch of different eating patterns for type 2 diabetes. And what we see again is that the low-carb diet won out. So it's not just a study here or there, it's many studies, and it's meta-analyses of those studies. I mean, we have evidence that we can back out of this epidemic. And I'm going to, please forgive me for anyone who's heard me read this before, okay? But I just think this is such an important study. I try to work it into all my talks. So everyone just sit back and listen to me. Don't look at it. Close your eyes if you will. This study is from 1976, okay? Hyperinsulinism will tend to establish a positive caloric balance in adipose tissue as insulin favors glucose and triglyceride uptake while inhibiting mobilization of fat. The realization that hyperinsulinism converts adipose tissue into a sink for calories implies that weight-reducing regimens should be specifically designed to allow a sharp fall in insulin levels. Thus, the avoidance of carbohydrates assumes special importance in the fasting obese, given this trend towards hyperinsulinism, not only because of the anabolic effect of insulin on adipose tissue, but because hyperinsulinemia per se produces insulin resistance. What if we listened to that before the epidemic? That was 1976 that was around. 1976. Again, we just go back and say, we got so out of control. Stop. Let's go back to what we used to know. So is there science, right? Wait a minute, we hear again, the eating patterns that have been around for type 2 diabetes are what? Plant-based, DASH, and Mediterranean. So we got low carbohydrate creeping up. Is there really enough evidence to support that? 20 randomized controlled trials, 5 meta-analysis, 10 other published trials. And how does that stack up to those old traditional recommended eating patterns? Here's how it stacks up, okay? This is what is in the literature, all right? So the idea that there's not enough evidence to recommend a low carbohydrate diet approach for type 2 diabetes, that is not a point of fact, okay? That is not a point of fact. In comparison, for sure, against the other eating patterns that have been recommended. Okay, so again, some of you may have heard us talk about this. Our trial that we have that continues, these are going to be a summary of the one-year results, and I'm really excited to report today that we have just finished the two-year paper. So hopefully we will see that getting published soon. And from 1 year to 2 year, the summary big picture thing is what we're excited to show in the 2-year paper is the sustainability of the results. So this is a 5-year, non-randomized. Again, as I was talking about before, some of the problems with randomization and not allowing patients to take a choice is really important when we consider setting up nutrition trials in the future. But it was a really large N. And the results I'm going to show you here are for the 262 patients in the trial who had type 2 diabetes. We will be submitting a paper looking at just the patients with pre-diabetes. So 262 patients with type 2 diabetes and almost 100 controls. One thing to point out too is that the mean time that these patients had type 2 diabetes was over 8 years. So if you actually go back and look at any nutrition intervention trial for type 2 diabetes, what you find is that most of them pick newly diagnosed diabetes because it's easier to deal with people who have just been newly diagnosed. Not only did we not do that, the other thing we did is we took people who were on insulin, which is oftentimes an exclusion criteria for other trials. So these were hardly cherry-picked patients, okay? They were morbidly obese, they had diabetes for a very long time, and many of them were on insulin. So how did they do? They did great, and 60% of the completers had their type 2 diabetes reversed at a year. So that's a lot of people, especially, again, once we're talking about how many people in this country are being impacted. What if we could reach all of them? We would change the epidemic, right? But it's also really, thank you. It's also really important to note for patient satisfaction just how quick this all happens too, right? So again, those people at the 10-week mark, that was impacting their pharmacy bill already, right? Probably, honestly, the next time they went to the pharmacy. And so for patients who have been burdened not only by the health problems with this disease, but by the financial ramifications as well, that's important, right? That they all of a sudden have one less medicine to pick up the next time they go to the pharmacy. So 7% of prescriptions for diabetes-specific medications were discontinued. We got all of them off sulfonylureas. I could do a whole lecture on why we should never use those sometime. Insulin, 94% of users had their insulin decreased or totally eliminated at a year. And so these were really important, meaningful medications that we were able to get people off of while they were improving. And of course, what's that translate into? That translates into cost savings. And that's important for employers, it's important for insurers, but in our day-to-day interactions, who is it important for? It's important for the people who are sitting right in front of us, right? It's important for the patients that it's affecting. And so do patients stay engaged? Right? I'm sure anyone who does this in their practice always bumps up against, well, I'm sure that will work, but people can't stick with it. Well, I mean, we're going to push way back against that. 83% retained at a year. And once again, the 2-year trial will focus on retention of the improvements that were made in the 1-year trial. So again, one of the side effects, the nice side effects of this is that people lose weight, even though that was not our main goal. Our main goal was working on disease reversal when it came to type 2 diabetes. And 80% of them lost over 5%, because one of the other questions that I've gotten is this just a few people losing a lot of weight? You know, no. I mean, we have the vast majority with medically significant weight loss. And once again, what about other risk factors? And the fact of the matter is, in this patient population, you can reverse their disease without making other things worse. Because, of course, what are we concerned about? We're concerned about LDL cholesterol. Now, our LDLC, the LDL cholesterol, did rise in this patient population, but that's a calculated value, and our triglycerides went down. A much more accurate, better risk predictor and measured number is the ApoB and the LDLP. They both decreased, actually. Not statistically significant, but the big point is here that they did not rise. So what we see is incredible improvements in other risk factors, even outside of the diabetes reversal. 12% improvement in the 10-year risk score as well. And one of the other things that I'll mention as far as this improvement in the risk score goes, we still, being conservative, counted patients as having diabetes, even if they technically didn't anymore. So the risk score would have been even lower if we'd been able to remove that. Liver functions improve significantly, and we know in this patient population that is really important because NASH is rampant, leading to cirrhosis in way too many patients. And here's a big one. Decrease in the markers of inflammation. If we see it's a 40% reduction in the C-reactive protein, that's as good or better than we get with statin trials. So that's pretty exciting as well. And here's a big question. So when we talked about study design and we talked about randomization and non-randomization, what is another problem with nutrition trials? Another problem with nutrition trials is, did people do what you asked them to do? And how do all other nutrition trials assess this? Food diaries, right? How accurate are food diaries? Yes, okay, we know that they're not accurate. And yet that's the kind of gold standard, if you will. Until now, I would assert, okay, because we knew if they were actually eating a ketogenic diet because we had a biomarker to track. So we looked at their beta-hydroxybutyrate levels, and yes, our patients were doing what we asked them to do. They had elevated ketones. So again, that gives us a little bit of or a lot of it, I would actually say, leg up on the assessment of actually doing what we asked them to do. So it won't work because, all right, so this is a new part that I've put in. It's the weight loss only, right? So we got a number of studies that show us that it's not the weight loss only. This is going back to that study 2 years where I said it was a low carbohydrate, low saturated fat diet versus a high carbohydrate diet. So here's the interesting thing. If you take a look at the people who started the study uncontrolled, over 7.8, okay? So the graph on the right, those people lost the same amount of weight. They lost the same amount of weight. But the A1C got better with the low carbohydrate group, okay? But they lost the same amount of weight. And the same thing here, when we talk about this metabolic ward study, how much weight had they really lost in that short amount of time? Yet look at the dramatic results that we have. Protein is bad for the kidney. We hear that a lot too. Creatinine in our study actually went down, and a well-formulated ketogenic diet can't be high protein, so we won't get into the protein for kidneys or not kidneys. That's a whole nother debate. But no study to date has shown a worsening in kidney function. People can't stick with it. They do. LDLC will go up. Once again, I already talked about this, which is that, again, LDLC going up as a calculated value, ApoB and LDLP actually going down, non-statistically significant. Kidney stones, because of elevated uric acid. This is an incredibly well-documented phenomenon. Uric acid does go up shortly once starting a ketogenic diet, but then it decreases down below baseline. Gallbladder. So this is another interesting one. This has really not been well studied. But anecdotal evidence on thousands of patients in my clinic is that we don't get gallstone issues. Every once in a while, you'll uncover an acalculous cholecystitis, right? That once you're eating fat and they're trying to squeeze and they realize that they can't. But as far as like all of a sudden having a problem with all the gallstones people formed when they were doing low-fat diets, we just don't see this. And I won't get into this. I know Nina's already touched this, but you know, I have a whole little bit that I like to discuss about this diet or about this study. And all the problems were with it, but I know Nina covered it, so I won't get into that today. I'll just say the biggest issue here is any claim coming from an observational study is most likely to be wrong. And that's been studied a couple of times. One study looking at it found it was correct 0% of the time, and the other study found it was correct 20% of the time. So we've always got to look at those with an air of suspicion. All right, so how do you support sustainable behavior changes? This is all great, but how do we get our patients to actually do it? And that is you have to support them from many angles. We like to say that we put the patients in the center, and we did this in the trial. Patients in the center with support coming from many different ways. So each of our patients got their own health coach, got their own physician who was able to safely reduce the medications. And the health coach was able to act on biomarkers that the patients were inputting, creating a biomarker feedback loop. So patient getting on the scale, which populates into an app that both the health coach and the physician can see. And then they can act on those numbers. The glucose gets put in, we can act on those almost in real time so that the patients can be coached on what was going well or what did not go so well with the meal right before the blood sugar or ketone, right? You don't have to wait 3 weeks ago, your weight went up, what happened, 3 weeks ago? We can actually get it to the meal right before the biomarker changed. And that's the way that we can keep people safe by reducing medications, once again, in almost real time. So to avoid any hypoglycemic instances. Patients have access to resources. That's everything from tell me a little bit more about cholesterol to I need to know what to bring to a 4th of July picnic and give me some recipes. And then the other really important thing for patients is they had access to a patient community of their peers. Because, they love to hear from us, but patients also want to hear from people who are in the same boat as them. So it really does surround them with support from all angles. Because although we wish we could blink and our environment changes and there wasn't a McDonald's on every corner, we have to work in the reality of what is right now. And so to walk out into this carb-centric world and be a patient who's struggling with metabolic disease, you need a lot of support to be able to make changes that work for you personally and that you can sustain over the long term. And the most important thing, too, is to give them advice that works, okay? And once again, in our experience, and the literature certainly supports, that is a low carbohydrate, high fat, nutritional ketosis plan. Doesn't require calorie restriction, allows people to eat delicious foods, and gives them results that they can see very quickly. Thank you. Thanks.
We have lots of time for questions. Yes, okay. So please come up. Go
ahead. Hi. So I've been following the protocol for 2.5 years, and I got my A1C down from 7.3 to 5.9.
Congratulations.
But when I hear the word reversal, I'm confused.
Okay.
Because mine only reversed until I eat a piece of toast.
Well, so what you would be confused about then is the word cure, and that's why we avoid it. Because we're not curing anyone from type 2 diabetes because of exactly what you just said. If they go back to eating the way that they used to, a piece of toast, a dish of pasta, then the blood sugar will instantly become a problem again. So we actually talked about what the right word is, because another word people have used is remission also. But honestly, I do believe that reversal is the most accurate, fairest descriptor to use. Because when we think about it, think about the cycle, right? We all know that our patients get into this horrible, vicious cycle. Their blood sugar goes up. They actually get bigger cravings, they're eating more carbohydrates, they need more medications, their body is kicking out more of their fat storage hormone. I mean, around and around and around we go. And so when we implement, again, a change in lifestyle, what is the honest thing? What exactly is happening? We are truly reversing out of that cycle. We're going backwards, okay? I would love to be able to say that we cure people, but that's not true, okay? Maybe someday we'll get there, but
Does insulin sensitivity increase with time?
Yes, and many studies have shown that, and including our 1-year trial. We had significant improvement in insulin sensitivity. Okay. But everyone is at risk still. I mean, anyone who's had this disease is at risk for it becoming a problem again, even if they've reversed out, which is one of the reasons actually that we encouraged our patients, even if they had reversed out of their type 2 diabetes, to stay on metformin, because that's indicated outside of just type 2 diabetes. And let's face it, even if they're doing well now, they are still at great risk for redeveloping a problem if they deviate into carbohydrates at all. So we need to make sure that the changes that we're asking them to make are sustainable for them personally. We talk about that from day one. And we always talk about what would happen if they go back to the way of eating, right? And then we want to understand that they're always going to be at risk, and that's why I think metformin in this patient population may be really a good idea in the long term.
Okay, I'm moving to Indiana. Thank you very much.
Thanks.
Hi, Sarah.
Hi.
Thank you for your lecture today.
Yes.
I've seen you so many times at Diet Doctor, and seeing you live is amazing, so thank you very much.
Thanks.
My question has to do with insulin sensitivity and sugar substitutes. Do you know if there's any insulin reaction to sugar substitutes like stevia or Truvia? I have a friend who drinks coffee every day with me, and he used to put like 10 packets of sugar every day in his cup of coffee, and then now he switched over to like 10 packets of stevia. So I just wanted to know what your thoughts are on that.
So that's a really great question, actually. And I think that this is an area that we have to be honest that we don't know that much about, okay? We know, I mean, sugar is bad for us, okay? I mean, I think we can all agree that that is not a good idea. But do we really have all the answers about artificial sweeteners yet? We don't, okay? So, all right, we got someone who has diabetes. Sugar's going to be terrible for them. I know that, right? I've got artificial sweeteners. I don't know the whole story behind them, okay? What do I do? Okay, and my answer to that is, we have a pro-sweetener crowd, and then we have a never sweetener crowd. And I think they're both missing the big picture, okay? Which is we don't know enough about this to say definitively one way or another. And number two, diabetes is terrible, and we have to do what we need to do to help people make a lifestyle change that is sustainable. And so if utilizing a little bit of certain sweeteners is going to get them there, then I think that's a reasonable idea. But I'm constantly trying to get people to look at that little bit. So for example, for your friends, one of the things that we do is no artificial sweeteners when people are beginning. No artificial sweeteners for the first couple of weeks, okay? Which again is not necessarily a sustainable thing. But if you do it like that at the beginning, the next time he goes completely off of it, the next time he tries to put something in his coffee, what's gonna happen? Ugh, right? And so therefore you've gotten him to decrease, which is great. Okay, and then we could get into a whole lecture about this. I give this lecture to my patients all the time. The difference between the non-caloric sweeteners and then maybe sugar alcohols as well. So I think the ones that we're recommending are xylitol or erythritol, not xylitol if you have a dog. Xylitol or erythritol, or sometimes stevia can be used, but be cautious how processed the stevia you're choosing is, like the Truvia is highly processed. You can get some that's less. So I say right now we need to do what we need to do to make behavior changes sustainable for people. And for many people, that is going to include some sweeteners. We want to try to get their taste to change by giving them an elimination period so that they can use less of them. We want to be upfront that we don't understand everything there is to know about sweeteners. Here are the ones that the evidence will show seems to be better than others. So I don't recommend Splenda as a general rule, for example.
Hi, my name is Ashley Clay. I'm a registered dietitian from Kaiser Permanente. My questions are two questions. What is the ideal body weight calculation being used to calculate the 1.5 grams of protein per ideal body weight? And then my second question is, my vegetarian and vegan coworkers are linking me to websites such as nutritionfacts.org, where they say that high-fat diet promotes more insulin resistance, and that's why they're not recommending high-fat diets to their patients. So I'm wondering if you have any comments on the insulin resistance of a high-fat diet, because I believe they're not restricting carbohydrate with the high-fat diet. So
Yeah, and so the evidence will show just the opposite, right? When you're restricting carbohydrates and you're eating fat, the insulin resistance scores decrease. And the other thing, and there's a line of argument that they use about, skeletal muscles and fat. And the interesting thing, too, about the idea of fat is let's not forget that it's the high carbohydrate diets that cause our triglycerides and actually the saturated fatty acids on those triglycerides to increase. It's not saturated fat that does that, right? When we eat a higher saturated fat diet, our triglycerides, the fat in the blood essentially, right, decreases. But more importantly, potentially from a cardiovascular risk standpoint, is that the fatty acids on those triglycerides are increased by carbohydrates, not the consumption of fatty acids. So again, what I would say is I would bring, a list of studies that show improvement in insulin resistance with a low carbohydrate diet, because there are plenty of those, and say that goes against this really good evidence from the literature. So, the thing that may be muddying the waters, again, and I know it was talked about at the end of Nina's lecture, was, are we talking about high carbohydrate diets and high fat diets? That's a standard American diet. That's not a great idea.
thank you.
Mm-hmm.
Thank you very much for all your work and for all the relief you're bringing to diabetics.
Thank you.
Did you see evidence for improvements in neurological functioning, particularly cravings and the experience of stress?
So that is a great question, and we did not specifically look at that within our study. I know that Elizabeth Parks from Missouri has just recently published a study looking specifically at cravings and seeing improvements. And stress is another thing. I think that's part of that emerging science where we're starting to see more and more people get interested in what are the potential psychological benefits of this. I think we're still, again, at that phase of more emerging science. Early studies are, and certainly a lot of anecdotal evidence is exciting, but I don't think that we can say definitively yet. We just don't have enough evidence on it.
Thank you.
Mm-hmm.
Hi, I'm a family physician and I do prenatal care. So I was wondering if you've seen studies on the very low carb or ketogenic diet for pregnant patients.
So that's a really great question. And so one of the issues, right, when we're dealing with pregnant patients is getting anything past an IRB, right? Because you put a pregnant patient in front of an IRB and they'll be like, don't do anything to her. But we're getting, I think, help from a really interesting place. And that is from the world of type 1 diabetes and also from the world of epilepsy. So, for example, a woman who has epilepsy and is on a lot of teratogenic medications, right? Seizure medications in pregnancy, we all know, do not mix, okay? So you're a woman and you get pregnant, you have epilepsy, you're gonna take the medications you know are bad, or you're gonna follow a ketogenic diet to control seizures during pregnancy. And many women are, of course, going to a ketogenic diet. And so Hopkins, Eric Kossoff and his group at Hopkins have already published a case series, and my understanding is they're going to be putting out another one. So a case series, like not something that has to go through an IRB because the women are electing to do this themselves. And I think we get enough of those, and my understanding is there's a group in Texas looking at this with type 1, patients who have type 1 diabetes and are choosing to do a low carbohydrate diet. We get enough of these that have proven to be safe. Eventually we'll get a large trial published. Right now, how I handle this is when a patient becomes pregnant, I say, right now we don't have enough evidence in this area. I recommend you move up to about 50 grams or so of carbohydrates a day. That way you won't freak anybody out. Right? Because the last thing she wants is everybody like hovering over, oh my God, you have ketones, and oh, this is terrible. So, stay on the higher end there, but you can still, babies, protein and fat is great for babies. Make sure that those 50 grams are full of vegetables and even some fruits. But carbohydrate restriction overall, especially with the number of women with gestational diabetes, is a good idea. We just, at this point in time, wouldn't recommend it to be in nutritional ketosis. Yeah, absolutely.
Hi, I appreciated your thoughts about clinical trial design in nutritional studies. In the geriatric world, people are talking about frameworks of mechanistic clinical trials versus pragmatic clinical trials, where mechanistic studies are very biology focused. For example, you're studying a heart disease drug, you study it in people who only have heart disease because you want to see the physiology. But in real life, people with heart disease have other problems too, and you need to know if that drug works in the normal person with heart disease, and that's a pragmatic study. So both have their place, both are important. Geriatricians think we need a lot more pragmatic studies, and I'm wondering if nutritionists in the nutrition world, if people are thinking about that framework and how you think about the role of these different styles of clinical trials for different purposes.
Yeah, I think exactly it. I think the problem that we've run into is not thinking about a variety of studies. We've fallen into this blinder. If it's not a randomized controlled trial in nutrition, it's not worth anything, right? And I think we're starting to see people get away from that mindset. Randomized controlled trials are great for drugs, and they can be good in other places. They can be good in nutrition trials if you're just looking at short-term effects, right? But when you're talking about long-term, where you're impacting everyone's day-to-day, that's where I say the randomization isn't good. So, I think that we need to look at more designs, because again, we fall back on the idea of using prospective cohort studies all the time in nutrition and in guidelines because we say there's so many limitations to clinical trials. That's one of the reasons that we give, right? But it's because there's a lot of limitations to randomized controlled trials in clinical trials, right? And we can't operate with those blinders on anymore. So we do absolutely need to be open to more. And I think the discussion of trial design in nutrition is becoming a more open, if you will, topic, and people are actually starting to discuss it. So I hope that we'll see some changes in that. So I totally agree.
I'm just wondering if in patients with normal A1Cs, but for whom you still suspect some insulin resistance, if you advocate for checking random fasting insulin or doing calculations like HOMA-IR or triglyceride to HDL ratios.
So yeah, I do. It's the triglyceride to HDL ratio is what, is kind of like the poor man's insulin resistance score, because, the most accurate way would be to do a 2-hour glucose tolerance test with insulin levels. I'll tell you the amount of times that I've actually done that in clinical practice is 0, because it's, it's a pain in the butt, the whole 9 yards. So you either use a triglyceride HDL ratio or you get like an NMR, right? And you can also use an LPIR score. But again, simple stuff that you probably have right in front of you is just the triglyceride HDL score. It's great. And people understand that, right? You can sit down and explain that pretty easy to people. And that's another way to engage them early on and motivate them. Mm-hmm.